one of the questions I always get, because how we stumbled into the anatomy trains several years ago when we started this degree was it meshed really well with how we viewed things from a clinical standpoint. In the clinical world, from a completely from a perspective of we see patients and do rehab for 8 to 10 hours a day, this meshed really well. It helped us explain a lot of the things that we were seeing and a lot of the things that we were experiencing that the traditional view of anatomy that we all learned didn't necessarily give us answers to. Now, right off the bat, this isn't, as we talk about this, I don't want you to abandon what you've learned from a traditional anatomy standpoint. That is important. Where muscles attach, what their isolated functions are, what nerves innervate them, all of that is still extremely important. The problem with that is that perspective doesn't lend itself to looking beyond where somebody comes in with their complaints. Somebody comes in with elbow pain and our immediate thought is what's going on with the elbow. We needed something that gave us answers and gave us a systematic way of looking at and understanding the body as a system, looking at and understanding the musculoskeletal system as a system, not along the lines of how we learned it from our anatomy classes. And it just so happened that was 2007-ish when we started this conversation. The first edition of Anatomy Trains came out in 2001, so it was still kind of on the fringe of, wasn't in the healthcare world yet, hadn't made its way into the personal training world yet. At this point in time, it was still kind of on the fringe of the edges of things, and we just happened to hear about it from somebody that we talked to. We were able to track down a copy, and as soon as we dove into it, we realized that this actually explained a lot of things that we couldn't explain. So that's how we ended up on Anatomy Trains. The question I get, because how we landed on this was it lined up really well with what we did, playing clinician 8 hours a day, treating patients 8 to 10 hours a day. But the questions we always got was, well, that's wonderful, but I'm at the high school setting. How is this going to help me? What's this going to do for me? Or I'm in the collegiate setting. What is this going to do for me? And couldn't have planned it out any better. This was yesterday. I got a call. So yesterday, high school basketball started. I get a call from a kid's mom that I'd taken care of the last couple of years when things had come up. Soccer's wrapping up. Basketball starts yesterday. They saw the soccer game yesterday. Basketball's getting going, and he was starting to have he'd been having some knee pain. He'd had surgery on the other knee earlier in the year, so they're a little on edge about anything knee-wise. So they're like, can you come take a look at this kid? So I go over, I take a look at the kid yesterday morning. Took a picture of his leg. He didn't have all his drawings on his leg. I did that. So don't worry, that's not the problem. Took a picture of his leg. He was complaining of medial knee pain on his right leg. No mechanism. When did it start hurting? I don't know. It just gradually has progressively gotten worse and worse over the last couple of weeks. Okay, when does it bother you? He's like, well, if I'm up on my feet all day, by the end of the day, it's a little on the achy side. Soccer, by the end of practice, not all the time, but sometimes if we do a lot of running, game goes into overtime, he's like, I'll notice that my knee's a little achy at the end. He's like, but it's not all the time. It's not every time I run, I feel it. He's like, when I run, I don't feel it. It's just when I'm done, my knees just ache. Complains that it swells occasionally, but when somebody tells me that their knee swells, I don't necessarily give that much thought unless I actually see a swollen knee, because people tend to feel the need to make things worse. And if something's swollen, it's bad. So if somebody tells me that it's swollen, I don't automatically assume that there's any swelling unless I can actually see it. He told me that occasionally it swells up. When I looked at him yesterday, there was no swelling, nothing like that. At the end of soccer season, he plays defender. Basketball season was just getting started. He hadn't had any basketball practices yet. and he kicks with his right foot. His knee pain was right there. Just below the joint line on the medial side, not over the MCL, really nothing at the joint. Range of motion was good. All of his special tests, I mean, it was relatively a clean assessment other than when I palpated and pushed on his knee, he had some pain there. The only thing that could recreate it was if I pinned down just above his patella and took his knee into forced extension, a little bit of hyperextension. He felt a little bit of discomfort with that. But otherwise, he didn't have any pain with anything I did. And the whole test came back negative. So, what do we do? You're in that situation. What do we do? From an anatomy standpoint, everything's fine. He has pain on palpation on his tibia. What am I going to do to fix that? Well, 5 minutes after, I spent maybe 15 minutes with the kid, and the first 10 minutes of that was talking to him about this stuff and just about other things. I actually spent about 5 minutes doing stuff with him, and then another 5 minutes doing stuff, and got him to where he wasn't having any pain. Got a text from him last night. They had a soccer game. They lost. How'd your knee feel the rest of the day? How does it feel after the game? He's like, I don't notice anything now. It's not bothering me anymore. It's not bothering me today. Haven't heard from him today. I'll check with him later today to see how things are. But 5 minutes, and the issues that he'd been having, the one time I could recreate the pain, was gone. Now, why I talk about this? Because if I come at this from a pure anatomy standpoint, it's his tibia. If I get wild and crazy from a thought standpoint, it might be periosteum, because that's where his pain is. Well, you could say that, where that is, it's kind of on the edge. So medial tibia is kind of pes anserine. What about the hamstrings? He didn't have any pain in his hamstrings. I checked that. So no pain in his hamstrings, no pain anywhere else really around the knee. Patellar mobility was good. So if I come to this situation with just a reductionist mindset, you have pain on your tibia, you don't have a mechanism. I'm not worried about a fracture, you're young and healthy. I'm not worried about any arthritic changes or anything like this at this point in time. It doesn't bother you all the time. I'm not worried about a stress fracture. And who gets a stress fracture there? So I can tell you it's not your MCL. It's not your ACL, it's not your PCL. I don't think it's your meniscus. You don't have any of the stuff that make me lean towards meniscus. I can tell you a lot of things that it's not. But what is it? And more importantly, for that kid, that person that's standing in front of us, they want something. They don't want to know what it's not. They want to know what it is. And more importantly, they want to know how to make it go away. So my thought process, which happens automatically, I don't actually just flip this switch and think, okay, this is traditional anatomy view, nothing, flip the switch, okay, now let's think about it from an anatomy training standpoint. This is just kind of how I've adjusted to where I see everything this way. My first thought when he had pain there, I'm like, okay, what anatomically is there? It's tibia. Pes anserine, you get a little bit of the attachments of the hamstrings that come in there. None of that is coming up as making me think that it's involved in anything that's going on. So my next thought is, what refers pain to the medial tibia? And the two structures that jump straight to mind are adductor longus, vastus medialis, which fall into the superficial front line and the front functional line. So I spent about 30 seconds and found a spot where he almost jumped up off the table. It was so uncomfortable. And I work up a little bit further and I find the second spot that brings him up off the table. And now, from a palpation standpoint, we have to be careful. I can palpate on anybody at any point in time and find a painful spot if I push hard enough. So my whole goal with this wasn't to push so hard that I found something. I'm just palpating and looking for spots that get his attention. I found two, VMO and adductor longus, both of which refer pain to the medial knee. So I spent all of 90 seconds on these two spots. So 90 seconds on the first spot, how does that, I'm sorry, 90 seconds on the first spot up in his adductor, how does that feel? Like it's better, I still feel it. Okay, 90 seconds on the second spot, come down here, how does that feel? I don't feel it at all. Okay, hop up, walk around for a second, let's talk a little bit longer, sit back down, try it again, now what do you feel? I still don't feel it. Only reason I did that was because I wanted him to get up, move around, and see if I actually found something, if he was just kind of being polite and nice and saying, you didn't help me at all, I need to go back to class. He might have been doing that, but he still wasn't having symptoms last night. So those two spots, how I got to them was thinking along the lines of fascial lines, led me to them, it goes away. Or I was able to have a positive impact on this kid's pain. It's not the first time that's happened. There have been several times I've been out covering middle school football, out at tennis, out at soccer. Somebody's come up, hey, this hurts, and spend just a couple minutes making sure nothing's going on from a traditional anatomy standpoint or from an assessment standpoint. And as soon as I'm going along, thinking along the lines that this is referred pain, find one or two spots and their stuff goes away. Which is quite a bit different than what happens. Somebody comes to us, we don't have that mindset. It's not your ACL, it's not your MCL, there's really nothing going on. Let's do some, finish practice if you're able to, and at the end of practice, let's try to do something else. So it gives us something that we can address right there on the spot. Like I said, people don't come to us for the things that we can't provide. You don't go to Chick-fil-A and not order the McGriddles and stuff when you look at the menu. You don't go there to see what they don't have. You go there to see what they have. And we have to keep in mind that when patients come to us, wherever they come to us at, the reason that they're coming to us oftentimes is because they're experiencing pain. The product that we're providing them is a resolution of that pain. We have to be able to do something to do that. And as an athletic trainer, we could be in many situations. We could be in many settings. We could be in a clinical setting. We have all kinds of access to all kinds of fancy equipment. Or you can be in a clinical setting where you don't have anything. Or you can be in a high school setting where you have tons of people, tons of things going on, not a whole lot of time, not a lot of equipment. You can be in a collegiate setting where that goes from no equipment to all the equipment on the planet, tons of time, tons of access. You can be in an industrial setting. The only thing that you know that you're going to have skill or tool-wise are your hands. So my approach has always been, if I can't fix them with my hands, then we have a problem. If we get so reliant on equipment or machines or this device or that device or this approach and that approach, I'm not saying those are bad, but what if in the absolute worst case scenario, can you still provide an adequate service to that person who's standing in front of you? If you say yes, wonderful. You have a valuable skill set. If you say no, you know how to use a lot of impressive pieces of equipment and tools, but you don't bring a valuable skill set to the table. From an employer standpoint, guess which one I want to hire? I want to hire the person that knows what to do with nothing. Because the only tools you're always going to have, regardless of where you're at, what setting you're at, what you're covering or what you're doing, are going to be your hands. If you have to rely on the ultrasound machine or you have to rely on the BFR stuff, those are good additional skill sets to have, but you're not always going to have those. So in this situation, we were able to do a little bit of trigger point work. We got to that trigger point work because of understanding how the fascial lines go together, where all the connections are, and we're able to get that kid taken care of rather quickly. As far as foundations for anatomy trains, yeah, we're gonna watch this. There's this nice little video. I don't know if you guys have heard this song before. Maybe. It's a Halloween song too. Can you guys hear that?
Bone stem, bone stem, bone stem, dry bone stem, bone stem, bone stem, dry bones. Now shake them skeleton bones. The toe bone's connected to the foot bone. The foot bone's connected
You know,
to the ankle bone. The ankle bone's connected to the leg bone. Now shake them skeleton.
The foot bone's connected to the, we've made fun of that. So these connections are there. We jokingly make them. But when we look at it from a soft tissue standpoint, there's still connections. And so what this does, it's very easy and one of the popular things over the last 10, 15 years in the rehab world and the healthcare world is to have the stance that everything's connected to everything else. And that really does absolutely nothing. It sounds wonderful. It looks good. It makes people think that, well, we're considering everything, but that doesn't necessarily explain everything. It's all connected. So what this does is when we look at it from a fascial standpoint, myofascial standpoint, what they've done in anatomy trains is they put these lines together that allow us to understand and comprehend anatomy from a little bit larger structural perspective. And it allows us to look at the relationships of different myofascial units that kind of work together. It kind of allows us to look at things from a group project type standpoint without having to take into consideration the entire anatomy. The assumption is, when they put this together, the assumption is that there is a body-wide interconnectedness, and that's the lens at which they looked at things. And so when they did this, instead of just saying everything's connected, they sat down and they looked at things, what connected groups do we have? So instead of saying everything's connected, now here are the fascial lines, and these fascial lines are connected together, and we can then break the body down from that aspect. And what I really find helpful with it is a step in the opposite direction of what healthcare has been leaning towards over the past 15 to 20 years, where we've really taken this reductionist mindset. Let's not just look at the shoulder. Now, I'm not just a shoulder specialist, I'm a total shoulder specialist. So the only patients I see are patients that are going to have total shoulders. Or I'm not just a therapist, I'm a neurotherapist. Or I'm a pelvic floor therapist. Or I'm a sports medicine therapist. Or I'm an orthopedics therapist. So we've kind of taken this opposite approach of I'm going to be very specialized in this one thing, and that's going to be my niche. And I'm going to know more about this one thing than anything else. And that's wonderful until we remember that specialization and nature do not go together. Ask the dodo bird. It got so specialized, it went into extinction. Koala bear, great example. Why aren't there any koala bears why do the only koala bears that live in the United States live in zoos? What was that? We're not like Australia year round. But B, do you guys know what koala bears eat? Eucalyptus leaves. When was the last time you guys went walking around Springfield and saw a eucalyptus tree? You're not going to. They have gotten so specialized, the only thing they can eat are leaves from one kind of tree. So the only place you see koalas are where these trees grow, which happens to be in Australia. If you want a koala to live in your backyard, plant a eucalyptus tree. It'll migrate there. So specialization doesn't always work the greatest. And from a healthcare standpoint, what's happened is things have gotten so specialized that if it doesn't fit into our little window of expertise, we don't know what to do with it, and we have to send them somewhere else. So what this does, it kind of takes a step back. Let's look at things from a little bit different perspective. Let's look at things from a larger perspective. Let's not consider everything else, but let's consider those things that are influential on what we're looking at. That kid yesterday, what influences the knee? What do I need to consider beyond the knee that's influential in the knee? And so it kind of gives us a framework of how to look at that. We don't need to watch that. Isolation. Isolation is good until we start to consider movement, and it gives us an incomplete picture of movement because it's very myopic. It takes, like I've said before, If I'm focusing on one thing, I'm missing everything else. So if I'm only focusing on one thing, I'm missing everything else. So a good example is, we're all familiar with the anterior pelvic tilt. We've all been taught about the anterior pelvic tilt. Pelvis that's tilted way forward, right? Creates elongated hamstrings, elongated rectus abdominis, you get shortened hip flexors, your quads are shortened up, increased lumbar lordosis, right? We've all been taught that. We all look for that. This is a true thing. But what if I told you that an anterior pelvic tilt is an incomplete picture, and there's actually 5 different things that can go on in the pelvis? There's 5 types of pelvises. There's a neutral pelvis. There's a pelvis that, the easiest way to think about this is, you have a neutral pelvis, you have a pelvis that can either be shifted anteriorly or shifted posteriorly, and then you have a pelvis that could be tilted anteriorly or tilted posteriorly. You can't have a pelvis that's shifted anteriorly and neutral, because we have to maintain vertical and not fall over. So if we shift anteriorly or we shift posteriorly, the pelvis is going to have to tilt a little bit to make sure we're staying vertical so that we don't fall over. So we can't have a neutral with an anterior tilt and neutral with a posterior tilt, or vice versa. So we have a neutral pelvis that's exactly how it's supposed to be. We have a pelvis that's shifted anteriorly or shifted posteriorly. Now, looking at these pictures, can you identify the pelvis that's anteriorly shifted with an anterior tilt, or the pelvis that's anteriorly shifted with posterior tilt? Better yet, can you see the neutral pelvis on here? Look at it for a second. Just guess which. Can you find the neutral pelvis? This one?
Yeah.
Who thinks it's this one? Anybody? Okay. Who thinks it's this one? Anybody? What about this one? No? This one? This one? Why is it so hard to tell? Let me ask you this. What would make it easier for you guys to tell if we're talking about an anteriorly shifted pelvis, a posteriorly shifted pelvis, or an anteriorly posteriorly tilted? What would make it easier for you guys to see? The whole body? How about we do that then? See how I set that up? I was really hoping you guys didn't miss a word. So now, my point with this is a very myopic view. We're only looking at the pelvis. And when you only look at the pelvis, you can't tell if it's an anterior or posterior shift. Now, I will say, the idea for this, for me to put this in here, hold on, let me find it. It's not this one. The idea for me to put this in here, and you guys should thank me now, because I found pictures to represent what I wanted to show you guys. I didn't use pictures from, this goes along with anatomy trains. Because they talk about, in the book, the company's anatomy trains, they talk about we need to take a larger view, a larger view, a larger view. And then they talk about the different forms of pelvises. And that's the pictures that they gave me. So you're welcome. I didn't share those up on here with you. But I wanted to show you, I didn't want to show you, but even here where they're talking about taking a larger view, they still only showed the small pictures. So it's easy to fall back into our natural tendencies. But it is easy, and when I was looking at that and they were talking about the different types of pelvises, I'm like, I can't tell the difference between each one of these. It would be a whole lot easier to be able to see the whole body. So I found pictures. The pink dot is where greater trochanter is. The yellow line is a vertical midline. And the blue line is where their pelvis is. So PSIS to ASIS. So we can see here, her greater trochanter is relatively right on her midline. Pelvis is relatively neutral. This is your neutral pelvis. So whoever said it was this one got it right. Anything else was wrong. So that's the neutral pelvis. Now, honestly, this one, I didn't expect anybody to get anywhere close to this. It's all just a guess. So, but now when we're looking at it, it's easy to see where the anterior posterior shift is because obviously his pelvis is shifted anteriorly. We have an anteriorly shifted pelvis and we have an anteriorly tilted pelvis. So we have an anterior shift and an anterior tilt. This one, you see his greater trochanter is behind midline. We have a posterior shift with a posterior tilt. Now notice it's not a giant posterior tilt because it's harder to tilt the pelvis posteriorly. But his is neutral, so we have a little bit of a posterior tilt. We look at the other two, slight posterior shift with an anterior tilt, and then an anterior shift with an anterior tilt. So when we look at this, if we only look at it through this lens of just the pelvis, all we can possibly see, if I asked you which pelvises are tilted anteriorly, we can see that, right? We have an anterior tilt. That was easy to see, a little bit of an anterior tilt. You know, if I ask you to identify two, this one obviously jumps out. We're a little bit closer here. But again, that doesn't tell us the whole picture. Okay, Brandon, why is that important? We have to consider the differences. Both this guy, professional model, I mean, I was blessed to have him work with me on this one. And this chucklehead animal here. No, you can see here, we both have an anterior pelvic tilt. I have a posterior shift. Aaron has an anterior shift. Why is that important? You guys both have an anteriorly tilted pelvis. The reason that it's important is look at our knees. What's my knee doing? Is my knee neutral? Is it slightly flexed or is it hyperextended? Slightly flexed. Slightly flexed knee on an anteriorly shifted pelvis. Look at Erin's knee. What's her knee doing? Hyperextended. So if we consider, well, it's just an anterior pelvic tilt. You're right, it is just an anterior pelvic tilt. But the ripples that it's causing elsewhere is drastically different. Because what's going on at my knee and what's going on at Aaron's knee is completely different. So if we just consider it from a musculoskeletal standpoint, that changes those muscles that are elongated and that are shortened. It's not what was on that first slide. More importantly, from a neurological standpoint, the input is completely different. So if both of us have an anteriorly tilted pelvis, if we come after this as the traditional anterior pelvic tilt that we're taught, we have to stretch out the hip flexors, we have to strengthen the hamstrings, one of us is going to get better. Aaron's going to get better. I'm going to get worse. If I'm your patient, I'm not happy. If Erin's your patient, she's going to love you guys. But do you really want your outcomes to be a flip of a coin? Because flip of the coin is not professional. So it helps when we're able to get more information. Because again, knowing all of that completely changes what I'm going to do with those individuals. One plan is going to lead to success. One plan is only going to make things worse. And how often, from a treatment standpoint, do we do things with patients and we make them worse? I think that, honestly, if I make a patient worse, that's the second. When I'm working with a patient, there's three possible outcomes. I can make them better, which is always what I'm shooting for. I can make them, they don't notice any difference. Or I can make them worse. Obviously, I always want to make everybody better. That's my entire goal. But if I can't make them better, I want to make them worse. And I want to make them noticeably worse. The worst possible thing that can happen is you just spent 30 minutes, an hour with that patient, and they felt exactly the same. Because they could have walked in, hey, wonderful, good to see you. Sit down there for 45 minutes. How do you feel? Exactly the same as when you walked in. Wonderful. Give me your copay. See you later. If that's what my interventions were as good as sitting in a chair, at least if I make things worse, I know I'm going after the right problem. I'm on the right path. I just did the wrong things. So if I make somebody worse, I know I'm going after the correct thing. What I chose to do wasn't correct. So now I know where the problem is. I know what not to do. Next time they come in, all of this stuff that I did that made them worse, that's off the table. I have to come at it from a different standpoint because I made change. So in this instance, you come in, Erin comes in, we apply the traditional approach to how you fix an anterior pelvic tilt to address that. She's better. Wonderful. We're on the right track. We're doing the right things. We continue to move forward. We get her out the door. I come in, we take that approach, we make me worse. Well, it's an anterior pelvic tilt. Obviously, Brandon's a problem. He's not doing the right things. We come back the next time, we do the same thing because it's an anterior pelvic tilt. It's obviously not working anymore. So Brandon, you're really not paying attention. You're not doing the things I want. You're doing this exercise wrong. Our tendency is to not look beyond what we think it is. And if we're hell-bent on seeing this as just an anterior pelvic tilt, and we're not seeing improvements, the tendency is we keep doing the same things over and over and over and over again. We're on the right path. We're just doing the wrong things. And the reason we're doing the wrong things is anterior pelvic tilt is not always the traditional anterior pelvic tilt. You have to understand where their center of mass is. Are we talking an anterior shift or are we talking a posterior shift? Because that drastically changes the situation. Like I said before, looking at things from a fascial standpoint, it doesn't replace our traditional understanding of anatomy. All we're looking at is, all this allows us to do is to see things through a different perspective. No matter what, the biceps brachii is always going to be an elbow flexor. It's always going to be a shoulder flexor. It's always going to be a supinator. That's never going to change. But the biceps brachii can also have a marked impact on somebody with knee pain. I've had several runners. They come in with knee pain, and the thing that makes them the most, that gives us the most improvement is addressing the biceps. The question is, if they're coming in with right knee pain, do I address the left biceps or the right biceps? It's really a matter of, we have to figure out which one's causing the problem, because I've had patients where it's left knee pain, addressing the left biceps makes it better. Ipsilateral, through the ipsilateral functional line. Because the ipsilateral functional line connects the left upper extremity through the trunk to the left medial knee. I've had instances where it's the opposite side. So left medial knee pain, right biceps connected through the spiral line, the right upper extremity is connected to the left lower extremity. I've run into both of those. And surprisingly, I've run into both of those quite frequently. Now, somebody comes with medial knee pain, I don't automatically think biceps tendon. I don't automatically think I have to address the biceps. Oh, you have medial knee pain? I'm putting my thumb in your biceps. No, I'm not that crazy. The kid yesterday, I didn't jump straight to his biceps tendon. It's on my list of things to consider, but I don't just go straight there because there's other things that directly refer pain to the medial knee, not have a fascial effect and can affect the medial knee. But in those instances where I've been working with somebody and I'm making them worse, I'm addressing things, it's not giving me the outcome I want. As soon as I find those things that aren't getting the outcome that I want, I don't just keep going after those. I expand that view, and eventually, in 1 or 2 visits, we come up and we look at the biceps. And if I've gotten to that point, it's usually getting close to our last resort. It's not uncommon for there to be a biceps issue. But again, it's not that first thing. So the biceps can affect the knee. It can influence the knee. It can influence the knee on the side or the opposite side occasionally. But it's always an elbow flexor, it's always a shoulder flexor, and it's always a supinator. It's looking at it from a fascial standpoint gives us another perspective from an understanding standpoint. We've talked about it a lot this semester. Human body is an integrated informational system. The fancy term for that is autopoietic. Constantly readapting, readjusting itself, constantly changing. You guys have all heard of homeostasis. We want to maintain homeostasis. That's not entirely true. The human body and our functions are more based off of an allostatic model, which is a learning model. We adapt and we change over time. And we adjust and we change what normal is, which is one of the biggest problems when it comes to a movement standpoint. Because if I've had back pain and it hurts for me to stand upright, what am I going to do? How am I going to walk around over the course of the day if it hurts for me to stand all the way upright? I'm going to do something that's not here. I might flex forward. I might flex forward and rotate a little bit. I might flex forward and shift my hips out to the side. I'm going to find a position that's comfortable that I can maintain. So if my back hurts and I don't want to fix it, or I don't have time to fix it, I don't have the resources to fix it, but I can walk around like this, I'm going to walk around like this. And guess what happens? Eventually, this becomes my normal. You ask me to stand up straight, this is what you get. In my mind, in my mind's eye, what my mind perceives I'm doing right now isn't this, it's this. My mind thinks and feels this is what I'm at. What we see is this, because this is what we have turned into our new version of vertical stance. This becomes our new neutral position. Our body adapts to that. The muscles shorten, certain muscles carry extra tension, certain muscles adapt to this position so that we get really efficient at being in this position. Our nervous system reconfigures itself to where it recognizes this as neutral. We do things, and this is one of the reasons why just stretching and strengthening things don't work. We stretch out. If I'm here, it's easy to say, well, your right obliques, right side of your trunk, all those are shortened. Your right hip flexors are shortened. Your erectors on that side are shortened. We need to stretch that out. So we do all kinds of stretching, and you'll get me to where, oh man, you get me to where I'm standing like this. In my mind, how do you think I feel like I'm standing? Way over here. Because now you brought me back to neutral. This has been neutral. So now I feel like I'm tilted way off to the left, even though I'm neutral. We've addressed the soft tissue. We've strengthened the dumb tissue. What we haven't done is address the nervous system. We haven't leveraged neuroplasticity. We addressed the flexibility. We haven't addressed the neuroplasticity, which is why I feel like I'm standing like this. And if we don't address the neuroplastic side of it, guess what happens? I walk out, I'm feeling a lot better. I walk out feeling like I'm walking like this, even though I actually look like I'm supposed to. I walk out the door, you address the soft tissue, didn't address the nervous system. Guess what happens? Over the course of the rest of my day, oh man, this feels so much better. Brandon didn't know what he's talking about. This is vertical. I'm going to come right back to this. I'm going to come in next time. How do you feel? I feel horrible. Well, you look horrible. No, I feel normal, but this is how I always walk. This is not how you always walk. We go back to what our neutral is, which is why we have to do things that leverage that neuroplastic change after we've opened that window by addressing the soft tissue. Because we're always changing. The human body is never staying the same. And that's an important thing to understand. We're never staying the same. Either tissues are adapting in a positive manner or we're adapting in a negative manner. We're either getting better or we're getting worse. We're never staying the same. At a minimum, we're constantly having a turnover of tissues. We're constantly replacing damaged cells. We're constantly replacing old tissues with new tissues. So we're constantly changing. We've heard about fascia from an anatomy standpoint, and how I was exposed to fascia. Fascia is just the thing that covers the muscle, which isn't entirely wrong, but it isn't entirely correct. Fascia is communicative, whole body system. It's how I was presented. It was the bag that was around the muscle, and that's all it did. It just contained the muscle. It's not an inert tissue. It has a regulatory sensory role. So as soon as we understand that, as soon as we understand that it has a sensory role, it provides input to the nervous system. That is probably the most overlooked component within anatomy trains, in my opinion, that's in the book. Because we completely undervalue the role of the sensory input that the fascial lines give us. Some people refer to it as a sinew, again, just the tissue that covers the stuff that covers the muscles. It is a tough fibrous net that's found everywhere in the body. It's not just around the muscles. And from a sensory input standpoint, it's one of the tissues that allows mechanotransduction to occur. Have you guys heard of the term mechanotransduction before? Basically, it's a way to take mechanical forces and create actual actual cellular function changes. The body takes this mechanical energy and turns it into electrical energy. The definition is mechanotransduction is the mechanism by which cells convert mechanical stimulus into cellular responses to a variety of mechanical loads. Cellular response, it's an electrical impulse. Remember the language, the nervous system only fire, the language of the nervous system is electricity. So when we talk about the cellular response, we're taking this mechanical input and turning it into electrical input, which then allows us to have an influence within the nervous system. So our myofascia provides a significant amount of sensory input to the nervous system. So the hypothesis behind anatomy trains is that muscles do have their individual action, but they also function in groups. And so what they've done, what Thomas Myers did with this is they went through and they defined what these different groups are. It is interesting, and I never thought about this until I got to looking into some of the stuff the book was talking about. We often think that a muscle attaches to the bone, right? That's not entirely correct, because the muscle actually, what connects a muscle to the bone? Tendon. Is tendon a muscle? No, tendon is a connective tissue. So the muscle connects to the tendon, that tendon then attaches into the bone. The epimysium, the surrounding of the muscle, the tendon blends into the muscle, or blends into the bone. So we actually don't have muscle that attaches to the bone. We have the attachment into the bone through this fascial connection, through this fascial tissue of the tendon of the epimysium. So this approach of looking at things from a little bit broader perspective isn't necessarily a new thing. This picture, this guy Hopke, I don't know how to pronounce his name, Hopke, something like that. German anatomist that in 1936 started to publish and talk about these schlings. I'm assuming that's a German word. And how different areas of the body were connected. The four that are referenced here, the serratus rhomboid, the external oblique adductor, the pectoralis internal obliques, the internal obliques, the gluteus medius, basically was looking at how a couple muscles tended to connect together and work together. So a little bit larger view from the isolated, this is just the serratus, but now the serratus and the rhomboids function together. This isn't just the pecs and the internal obliques function together. This isn't just the internal obliques and the glute med function together. He started to take a little bit broader look. Now, the problem with this, it was all focused on the trunk, and it was only a couple muscles. So it's a step in the right direction, but not a body-wide, system-wide approach. So this isn't necessarily a new way of looking at things. People have looked at trying to extend our view of anatomy for quite a while. This is just one of the first ones. This is one of the first individuals that actually published anything in regards to this. My first introduction to fascial slings was through Andrew Vleeming and Diane Lee. They talked about the slings. I think originally when they talked about it, they referred to them as a serapes. Basically, it's just a wrap around the body. They had the posterior sling, the anterior sling, the lateral sling. And when we look at this, when we look at that anterior sling, they did take a larger view. Right hip flexor to the right adductors, to the internal obliques, to the external obliques, to the serratus, to the rhomboids. Basically connected hip flexors here around the body to hip flexors on the other side. More than two muscles, but still very much focused around the trunk. Posterior sling, right gastroc to right hamstring, to right glute, to left lat, to left pec, to right pec, and then wrapped around. So now with their posterior sling, we basically connect back of my right leg through the chest to the back of my left leg, a larger view. I couldn't find a picture of the lateral sling. But again, taking a step in a better direction, we've still now completely neglected the arms, and we've really only considered the backside of the legs. And more importantly, with these, there was no, one of the things when Thomas Myers laid out anatomy, the fascial lines and anatomy trains, he had some very specific rules and reasons for why these different fascial lines were put together. And he outlines that at the very beginning so that there's a clear understanding of why these lines function together and why certain muscles are included and why certain units, certain tissues are excluded. These are on the right path, but they didn't have any, their logic for what muscles were included and what muscles were excluded, they didn't have a solid foundation for that. And so that was one of the things that Thomas Myers tried to lay out before he started to lay out the fascial lines. Vladimir Yanda talked about upper cross, lower cross syndrome. You guys familiar with that? Forward head, and again, forward head, forward hips, anterior tilted pelvis. Again, all of this is good stuff. I learned this in school. Again, though, the problem is like at the beginning, when we talked about the picture of Aaron and myself, we both fall into the lower cross syndrome. However, we have different versions of a lower cross syndrome. The traditional approach here won't work for me. It'll work wonders for Aaron. So we have to consider, this is good, but the problem is it only considers shoulders and neck, it only considers hips. So a step in a better direction, but not necessarily, again, a total body approach to this. The upper cross, lower cross syndromes, that was one of the places where we first started to assign faults or assign blame, which is where we have tight upper traps, tight levator, tight pecs, weak lower traps, weak serratus, weak neck flexors, which then means, obviously, if that's the fault, the solution is the exact opposite of that. We strengthen the neck flexors, we strengthen the traps, the serratus, we stretch out the pecs, we stretch out the upper tracts and the levator. That must fix the situation. That's not necessarily the correct logical step with that. And that was some of the problems that people stepped into with this, is they see this, well, if somebody has a forward head and rounded shoulders, it's easy, I just do the opposite. That's not necessarily going to work all the time. And then you just have the internet hacks that take stuff and completely rename it. This is the deep core chain. If you've looked at anatomy trains, you'll realize that the deep core chain is the deep front line. It's literally the exact same picture on page 146 of anatomy trains. So it didn't even change the picture, just change the names. This is our fascial line. So you'll run into all kinds of internet hacks out there that aren't original enough to come up with their own information, but they use other people's and call it something else. So drives me nuts. What the evidence has found, and I mentioned this before. The first, because the question always comes in, well, what does is anatomy trains evidence based? First book, the first edition came out in 2001. This line was in that book, it's in the fourth edition. This book reaches ahead of peer-reviewed research to present a point of view that seems to work well in practice, but is yet to be validated in evidence-based publications. They said that from day one. And remember, when I told you how we landed on this, why we landed on this, it aligned really well and helped us explain things that we couldn't explain. There was no research that supported anything or gave us any information. Because from a research standpoint, research follows practice. Research, you guys have all had some level of involvement in research. When you're trying to nail down your variables, big variables or small variables? Small. You have to be looking at one thing. And the less uniform that one thing is, the less likely your research is to get accepted or to move forward. It's got to be very focused. The problem with research is we have a lot of research that says what the biceps does from an EMG standpoint with this exercise, that exercise, and whatnot. We have tons of research on what the most influential, what exercise creates the most EMG activity of the glute medius. That's easy research to do. We don't have research on the fascial lines. At least in 2001, they didn't have research on the fascial lines. That has changed a little bit. I don't remember the date of this. Is it on here? 2016. They did a systematic review on some other articles that had looked into fascial lines. And basically what they came back and looked at, the question they were trying to look at was these lines that Thomas Meyer laid out, is there any actual anatomical support for this? Is there any actual support for how he outlined his lines? In 2001, he said it, this works, but there's no research for it. What they found in 2016, based off of research that has been published about this, there was strong evidence to support the superficial back line, the back functional line, and the front functional line. There was moderate amount of evidence to support the spiral line. And there was moderately strong evidence to support the lateral line. They didn't look at any of the arm lines. And they didn't have any support for the superficial front lines. So they did find quite a bit of support for the fascial lines that he laid out. Not all of them, but some of them. Another systematic review that came out, they basically went through and did something similar. What they found was in the superficial back line, they could support the fact that forces were transmitted from the plantar fascia up into the Achilles, from the hamstrings to the gastroc, from the hamstring up into the sacrotuberous ligament within the superficial back line. The back functional line, they did find that there was a connection from the lat to the opposite glute medius. Front functional line, they did find a force transmission from the adductor to the opposite rectus abdominis. So research is starting to support the lines that they laid out. The problem right now, one of the limitations with the evidence is who's going to let me dissect your arm right now in class? Anybody? What if I gave you, like, I told you you get an A in class? Mike said, maybe, let's go. The problem is, from a dissection standpoint, what are they dissecting? Cadavers. What don't cadavers have? An active nervous system. Because remember, one of the components of the fascial lines that I said was very important was its sensory role and its ability to generate mechanotransduction. That can't happen in a cadaver because they don't have an active nervous system. So one of the limitations with the research is the only thing they can look at are the fascial connections. We can't look at the sensory input. We can't look at the ability of the mechanotransduction to take place because nobody's going to volunteer to have their fascial lines dissected when they have an intact nervous system. So we are missing the nervous system with this. But I swear I didn't plan it out like this. It just so happened this lecture is falling on Halloween. We have a solution. Zombies. Zombies have intact nervous systems. Kind of. Because zombies, according to all the internet research on zombies, and I've been researching zombies for the past month because it seems like between Halloween and zombie movies, there's all kinds of stuff on, especially Zombies 3 just came out on Nickelodeon, or the Disney Channel. Disney Channel. We watched it at our house this weekend. Got some interesting input on zombies. What I found out about zombies is zombies use their nervous system to coordinate muscular activity. But they don't register pain. So that means they give us motor output but not sensory input. So zombies aren't even a good option for us. So from a research standpoint, we don't have any good way of looking at the sensory component of what the fascial lines provide. Now, this is a video of a patient from a couple years ago. Needle, that's his left leg, that's the spine of his tibia. So that's just lateral. So that's the needle's in one of his perineals. I don't know which one. I didn't put the needle in. Needle's in his perineals. When I play the video, I want you to watch the needle. This individual, we were trying to multitask. So we were needling him, we were kneeling below his knees and doing some soft tissue stuff up in his trunk. And it just so happened, I wasn't the one that was working with this person. I was standing there talking, which is right in my wheelhouse. And I'm standing there talking, I'm like, hey, what are you doing? To the clinician, I'm working blah, blah, blah. I'm like, she's like, why? Because the needle's moving. So then I asked the guy laying on the table, I'm like, you moving your leg? He was like, no. Huh, that's interesting. The needle's moving. Like, the needle was moving. He was relaxed. He wasn't moving. She was working up in here, and the needle's moving. So I pull up, they stop. I'm like, no, keep going. Let me pull out my phone. I want to record this. Keep doing what you're doing. So I want you to watch this needle. It's not moving a little. It's moving a lot. His knee's not moving. Right now, she's working up on his lateral hip. She's doing tissue glides over his greater trochanter. For the skeptics in the room, okay, she's doing tissue glides over a greater trochanter. Obviously, that's pulling the skin, and the skin's what's moving this. Let's watch this again, and I want you to watch the skin. Is the skin around the needle moving? No. The movement is coming from deeper tissues. So again, this just so happened when we saw this, holy cow. It's a great example of how we can work in one area and have significant influence in far-reaching areas. Without the needle, we would have never noticed that. He didn't feel anything in his leg. He didn't know anything was going on in his leg. But obviously, we were changing this, we were manipulating the sliding and gliding of the tissues below the surface of the skin and having a significant effect on that, which that falls into lateral line. And one of his big problems, one of the things that we were trying to target with this guy was addressing his lateral line. And so by addressing his hip, you can see that we were making change. We were changing things. We were creating movement in that lower leg as well. Now the rules of the fascial lines. There's a whole chapter related to this in the book. I'm only going to touch on these, not because you guys need to know the rules so well that you can do a dissection and figure things out, but just to understand how things fall into certain lines. Because a lot of times as we start going through the lines, a question gets asked, why is this muscle in here? Why are these muscles excluded? So we're going to talk about these real quick. The overall intent when he laid out these fascial lines was to identify lines where the continuity of the lines created lines of force transmission, created lines of transmission. Direction's important. All the muscles have to be going in the same general direction. Depth is important. Superficial muscles versus deeper muscles. That's one of the reasons why there's a superficial front line and a deep front line, because we're talking different depths. Intervening planes. Easiest way to think about that one is if something cuts through and interrupts the line of transmission. I have an example of that one. It's important to understand the stations, because I think, and when we talk about station, we're talking about bony attachment points. Tibotuberosity is an example, because oftentimes when we think about fascial lines, and one of the mistakes we made early on when we were teaching the fascial line was we only emphasized the muscles. As we've learned more and seen more, it's very important to understand the stations as well and the bony attachments that are involved, because of the rich sensory input that we get from the periosteum, especially when we have areas that they call roundhouses and switches, which are where we have multiple muscles coming in, multiple tissues attaching to a bony area, creating different lines of pull. So think of the ASIS, the pubic bone. You have multiple muscle attachments all creating different lines of pull. And then the last thing, they talk about expresses and locals. Easiest way to think about this one is expresses are the multi-joint muscles. They call them the polyarticular muscles. They cross multiple joints. The locals are the single joint muscles that only cross one joint. So we talk about the direction. If we look at the back of the body here, the superficial back line, we can see muscles of the lower leg are running basically from the foot up to the knee. See the hamstrings running from the knee up to the hip. Sacrotuberous ligament connects here, and then we see the muscles of the back running in the direction this way. Obviously, the rhomboids are going at a different angle. They're not included in this line. The serratus posterior inferior are running perpendicular. They're not included in the superficial back line. And the deep hip rotators are running opposite or at a perpendicular angle. They're also not included in the line. Now, out of those, the rhomboids are included in upper body lines. The serratus posterior inferior aren't included in any line, because there's no other muscles that line up, share that direction. So when we're going, and this is again where it's important to understand both. The serratus posterior inferior is not included in any fascial line, because the direction that they don't go anywhere. But we can't completely forget them and omit them, which is where the traditional understanding of anatomy, we have to know that it's there, we have to know what it does, even though it's not part of a fascial line. The deep rotators of the hip, another great example, they're not included in any of the lines. They're extremely important, but again, they don't go in a direction that lines up with any of our fascial lines. So we can't just exclude those. And we definitely can't exclude those, because some of them make up our pelvic floor. So they are very influential, but they're not a part of the fascial line. So this is where having the understanding of a traditional anatomy view, as well as understanding the fascial lines, becomes important. We have to be able to understand both. This is an example of a roundhouse to ASIS. See, we have the ASIS, obliques pulling in one direction. We have the iliacus, line pull a different direction. We have our glutes, medius, glute minimus, pulling in a direction. We have rectus femoris. So that ASIS, from a force transmission standpoint, it's getting pulled in a lot of different directions. Why is that important? Sensory input. There's a lot of sensory input that's happening with that, and it's having to mitigate a lot of those forces and having to help transmit a lot of those forces. It's also important, fascial tuberosity. We can see we have several muscles that attach here up into this. Greater trochanter, several muscles. The sacrum gets overlooked a lot. We have several muscles that attach to the sacrum. Again, all pulling those tissues, all embedded in, all interwoven into the bony, the periosteum, creating different lines of pull, which is going to have an effect on sensory input. As far as talking about here, we can, the locals versus the express. We have the long head of the biceps, which crosses at the hip, crosses the knee, so it creates hip extension, creates knee flexion. We also have the short head of the biceps, which only functions at the knee. So one of the reasons why short head of the biceps, when we look at the, that's why short head of the biceps, long head of the biceps aren't always included in the same lines all the time, because they do have different functions. They do have different, one's a local, one's an express. All right.